Hello, everybody. Welcome to another educational presentation by MedMark Publishing. Tonight, we welcome Dr. Danny Eckert, who's a PhD researcher in Australia and the author of many interesting papers. My name is Dr. Steve Karstensen. I'm Chief Dental Editor of Dental Sleep Practice, and I'm happy that you're able to be here for a Panthera-supported webinar. In our webinar today, we'll review pathophysiologic consequences of OSA, examine non-CPAP therapies for that, and discuss which patients might be most suitable for oral appliance therapy. Before we get started, I'd like to invite everyone to use the Q&A feature in the control panel to ask any questions. They'll be answered at the end of the session as time permits. Now, I'm pleased to introduce our speaker. Danny Eckert is a PhD Matthew Flinders Professor at Flinders University in Adelaide, Australia. He serves as director of the Adelaide Institute for Sleep Health, where he leads a comprehensive basic sciences and translational research program comprised of more than 60 multidisciplinary sleep researchers. His research focuses on the identification of the causes of sleep apnea, optimization of existing therapies, and the development of new tailored therapies. Dr. Eckert is most well known for his pioneering respiratory endophenotyping work, which has led to a new precision medicine therapeutic framework to understand and treat OSA, and for his research on novel pharmacotherapy. He has published more than 200 articles in the leading sleep respiratory medicine and other cross-disciplinary general medicine journals. Dr. Eckert's previous appointments include Professor of Medicine at the University of New South Wales in Sydney and Principal Research Scientist at the Neuroscience Research Australia, where he retains affiliate appointments. From 2006 to 2011, he was an assistant professor at Brigham and Women's Hospital, Harvard Medical School in Boston. So thank you so much for joining us, Dr. Eckert. We now turn the webinar over to you to learn a whole lot more about today's topic. Thank you, Danny, for showing up and being here for us. I know we're all going to learn a ton of stuff.
Look, thank you so much for that very kind introduction. It's great to talk about this topic that's obviously very close and dear to my heart, and one in which I'm very passionate about. So today I will be talking about new approaches for physiology-informed precision care for obstructive sleep apnea. Here's my disclosure slide. I am funded by our National Health and Medical Research Council of Australia, equivalent to the NIH. But given that my work is very much focused on not only understanding why people get their sleep apnea, but developing new tailored therapies, I work with a range of industry partners as listed on this slide here. Just to give you a bit of scope of where I'm speaking from today. So down here in South Australia, here's a picture of our facility here at the Adelaide Institute for Sleep Health at Flinders University. And all of these orange dots are actually dots where our campus, our university, I should say, has a presence throughout this rather unique landscape that is Australia. And I just want to acknowledge that the work that I do, where we are here in Adelaide, South Australia, is on the traditional lands of the Kaurna people of the Adelaide Plains, where learning and teaching has been taking place for tens of thousands of years. Okay, so getting back to the crux of, why we do the work that we do, and it really comes back to this question, why do we need new diagnostic and therapeutic approaches for sleep apnea? And I would argue that the current one-size-fits-all trial and error approach is cumbersome, time-consuming, and costly, and is really failing too many of our patients with sleep apnea. And here's just a schematic example, recognizing that there's different models of care out there, but this is one that's not uncommon. First, you need to recognize that you've got a problem that requires care. You might have a discussion with your primary care physician, who then refers you to a sleep specialist. There's wait times throughout the process, potentially, including for a diagnostic study. Now, thankfully, with technology, many more studies are being performed in the home, whereas wait lists can be very long for in-lab. But still, there's wait lists for home studies as well, particularly level 2. You then got to get the results back, which are manually scored and interpreted, have another appointment with your sleep physician to interpret those results. And regardless of, your particular causes of sleep apnea, your profile, actually the numbers show us that over 90% of the time, if you get a diagnosis with sleep apnea, you're going to end up on CPAP therapy, at least for a trial. Now, again, technology's helped us. There's now auto-titrating machines, so you don't necessarily have to come back into the lab like you used to figure out what pressure you need to be at. But despite the advances in technology, roughly half of those who prescribe CPAP therapy, when you bring them back a year later, they're either not using it at all, or they're using it less than what we know is necessary to have a beneficial effect on health and well-being. Now, others, again, so if you're lucky, you might come back into the system and see the sleep doc again. And perhaps oral appliances might now start to be discussed. A minority of patients may have got there immediately, particularly those that are mild or moderate traditionally. And again, there's a bit of a trial and error process. And even when we do our best here, it's roughly half of those that are prescribed oral appliance therapy have a therapeutic response on average. And very rarely are other therapies discussed or mentioned. So this is problematic. And just to give you a few examples here, this is a pivotal study done in a randomized trial done in Australia, over 10 years ago now, by Peter Sestuli, Ron Grunstein and colleagues. And what they found in this nice, well-designed trial was actually the health benefits of CPAP versus oral appliance therapy are comparable. And so we've known this a long time, and yet I just told you the numbers on the prescribing rates. They don't match up, at least in many places throughout the world, including Australia and the US. Now, that is mainly because, yes, CPAP is more efficacious, but as I alluded to, there are tolerance and compliance issues for many. And what I hope to get into this presentation is to show you why the physiology is important here in predicting responses, not only to CPAP, but other therapies as well. Conversely, people tend to wear the oral appliances more, even though they're less efficacious. The fact that they're wearing them more, overall, the health benefits are comparable. Other therapies, just to give one example, and I'll talk about others that are emerging in this presentation. So here's a study led out of our center. It was a multi-center trial looking at multi-level upper airway surgery and its potential to reduce sleep apnea severity in the short and indeed the long term. And the long-term data have also recently been published. And as you can see here from this study in the JAMA, it was indeed beneficial with, for half or more of the participants that were randomized in this study. So there are other therapies out there. So, yes, I've talked about CPAP, and this is a rather unrealistic example of wearing CPAP with glasses on and your mouth open, which would make a horrible sound whilst you're awake, and reading, obviously bad for sleep hygiene. But nonetheless, while there may be a minority that are able to pull this off, for many others, as I mentioned, CPAP, for a variety of reasons, feels more like this scenario. It could be a physical burden or other issues, claustrophobia and so forth, that can limit the uptake of CPAP. So overall, sleep apnea really is a heterogeneous disorder. So the optimal, I should say, therapy or therapies likely varies between people with sleep apnea. And this is where these precision medicine concepts come in. And this is really what I'll be focusing on the talk today. But before I get to the sort of physiology, I just want to highlight some of the recent research that we've been doing on the technology side, really on the diagnosis and monitoring front, that really has allowed us to identify and answer a lot of important sleep health questions that we haven't been able to do previously. And we think there's likely to be a lot of scope in using these kind of tools moving forward. So, of course, we're all familiar with standard polysomnography and the detailed measurements that we obtain from either a night in the lab or in the home with a level 1 or 2 device. Now, as I'll show you, my view is that we can do a lot more with that detailed information, and that can be very useful to help estimate what's going on with the physiology and inform clinical treatment decisions by using that information more smartly, or in a smarter way, I should say. So I'll get into that. So absolutely, polysomnography has its use, but it's typically single time point, and often that diagnosis sticks with people for life. It's rare to have multiple diagnostic studies. Here's an example of a different technology. You slip this under the mattress. It can pick up your breathing motion via pressure sensors. It's got a snoring sensor in there. It can pick up snoring sounds. It can infer heart rate. And the technology is really quite amazing in terms of what it can do. And so we looked at this and we used the global sample from over 65,000 people, of people that had that in their home for approximately 6 months. And what we found, and this, is about 80% as accurate as a standard PSG, and we didn't quite believe that ourselves until we validated ourselves. We got the same number as the company in terms of how reliable it was to estimate versus PSG. So that gave us a bit of a confidence to lean into this. And what we found was, not surprisingly, and this is multi-night, so this is the average over 6 months. So for the first time, we can look in the home environment objectively over a large sample and big numbers, and not surprisingly, lots of sleep apnea. In this case, moderate to severe, 10 or 15% of women, 20-25% of men in this, recognizing it was a consumer sample. And the next point, I guess, is that these single night recordings actually lead to misclassification rates, and I think this is really important for the field to recognize, of 20 to 50%. So here's what we showed in this. So there's both under and over treatment that will happen if you just do a single time point sleep study, and in fact, if you want to put numbers on that, about 15% of the cases are likely to be overtreated, and about 30% are undertreated due to misclassification of the variability. And that variability is both physiological, and it's to do with the way we score and the manual scoring and things that can mediate that. So physiologically, if you sleep on your back more than one night or the other, maybe you've got a blocked nose for some allergies, or maybe you've had alcohol on that night. These will all lead to fluctuations in your severity of sleep apnea physiologically, as well as those manual scoring and the noise that comes with that. So, as I mentioned, it's less of an issue for those that come back with a diagnosis of severe sleep apnea. The misclassification rates based on single night are about 20%, but if you go in that mild group in particular, it's more like a 50%, and moderate somewhere in between. And as you can see from what we did here with, doing these estimates over multiple nights, the misclassification rates go right down with the more nights that you do. And here's where we think this sort of novel technology may be helpful. So here's a study. We ran these simulations, and basically we had a relatively large group of people where they took multiple blood pressure recordings throughout a 9-month period, and we were able to detect who had incident hypertension. So they didn't have it in the first 3 months, but they did by the last 3 months. And we wanted to see whether we could detect a relationship between sleep apnea and that incident hypertension in this cohort. And so we ran these thousands of simulations, and basically what we found is if you're just doing a single night diagnosis, about 40% of the time you're going to miss that relationship between sleep apnea and hypertension. And you can see what happens as we increase the number of recording nights, we get more confident with the diagnosis, to the point where, after a couple of weeks, we rarely miss that relationship. So we are, in fact, finding the right people and seeing that relationship between sleep apnea and hypertension. If you do it for a month, then you basically, statistically, you're never going to miss that relationship. And in fact, the strength of the relationship got stronger as we did more and more nights, as shown here. Okay, and I guess if you're still sort of thinking, well, is this, how can a little device like this possibly do this. So here's again, we wanted to just say, okay, if we take the average AHI using this mat that doesn't even touch the person, you take the average over a 6-month, is there a relationship, as we know there is, with standard ways of measuring sleep apnea and hypertension? And you can see these very nice, clear dose-response relationships. The more severe your average sleep apnea was, the more likely you are to be hypertensive. But more importantly, and getting back to that point, how can we use this technology to answer questions that we couldn't previously? What we've been able to do here is actually identify what we think is probably a very important clinical phenotype. So what we've done here is break down over the course of that on average 6-month period, look at the night-to-night variability of the AHI, or that estimate of the AHI. And so we've got an average value. So it's 2 groups, one that comes back with, between 5 and 15. So either, depending on how you classify it, mild or no sleep apnea, and then a group that's with moderate to severe on average. But within each of those groups, some varied a lot night to night. So some tick along and they have pretty much the same level of AHI every night with very little night to night variability. And others had a lot. And we've broken that down in the quartiles. And you can see that those with the most variability down here, and almost independent of the severity, and remember, these are very mild now, 5 to 15 on average, the risk of hypertension was actually more than those that just had stable but severe sleep apnea on average. So there's something about having variations in the night-to-night severity of your sleep apnea that seems to be associated with sleep apnea. And obviously, we can only get a sense of that if we're recording over a number of nights. And just to make the point, other things, we typically focus on that AHI and the diagnostic side. But there's other very important sleep health components. And what we, again, using this technology that we are able to show is actually just the timing of your sleep, independent of sleep apnea, independent of the duration. If you vary the time in which you go to sleep throughout the week more than 30 minutes, you're 30% more likely to be hypertension from these analyses. More hypertensive. And if you vary it by more than 90 minutes, across the course of the week regularly, you're 90% more likely to be hypertensive. So, the importance of a good sleep routine is something that we can also establish from these kind of monitoring tools. Lastly, here's one that's just been published in Nature Digital Medicine, again, using this approach in a community, a consumer sample, over 12,000. We monitor them for 9 months, and we, for the first time, we can objectively measure. Now there's different ways to measure snoring, but at least we've got a microphone and we can actually put some quantifiable numbers on this. A big part of the population snore a lot. 30% snored regularly for more than 10% of the night in this sample, and here are the other corresponding numbers. And importantly, there was a high proportion of time spent during the night just with snoring, independent of sleep apnea, was basically doubled your risk of being hypertensive. And of course, if you add sleep apnea on top of that, you double the risk again. But here, the important finding is, maybe snoring in of itself, and this kind of makes sense physiologically, where you're working harder to breathe, you're putting strain on those structures around the carotid artery and maybe plaque formation. Snoring in of itself may not be benign, as these data suggest. All right, so there's just a sort of bit of background on the technology. Now I'll get into pathophysiology, targeted therapies, and how we can roll this out in the clinic. So, traditionally we've thought about sleep apnea as primarily an anatomical problem, and indeed it is. But as you can see from these MRI images, so based on that sort of knowledge, we'd say that this person here with a nice wide open airway on the left does not have sleep apnea, whereas this person with a narrow, crowded airway with adipose tissue, you can see in the middle of the genea glossus here, we would suspect does have sleep apnea. But actually, with the use of these sort of MRI tagging techniques, we can see that even though in this example, this person's got, the static, so if we just look at that airway, we'd say, wow, this is a crowded airway in this obese individual. This person does not have sleep apnea because their muscles work so well at keeping that airway open. So they've got fantastic upper airway dilator muscle function, and therefore they're protected from sleep apnea. And actually the opposite is also true. So even in people with just a little bit of an anatomical problem, if their muscles aren't working well when they go off to sleep, then that in of itself can cause sleep apnea. And we see these different types of patterns. So these are just quiet breathing, awake in the MRI. And we can see here, in this case, the uvula, there's this sort of counterproductive motion. Bit of anterior motion at the start, then the uvula is flapping back on the posterior wall. And this person's got moderately severe sleep apnea. And here's another scenario. Here's someone where their muscles really, in this very crowded airway, aren't resulting in any motion whatsoever during quiet breathing. And the airway remains very narrow. And not surprisingly, this person has, very severe sleep apnea when they go off to sleep. So it's that interaction between anatomy and non-anatomical causes that really drives the pathogenesis of this very common sleep-related breathing disorder. So I talked there in those examples about the interaction between muscles and anatomy, but we've also got these other two traits, what we call the respiratory arousal threshold, so how easily you wake up when your airway narrows during sleep, and the level of pressure or effort that you apply seems to be the key trigger, at least a surrogate of what's waking people up. And then lastly, what we call respiratory control stability or high loop gain. It's really the sensitivity to carbon dioxide, the main driver of breathing during sleep. Some people are just too sensitive to small changes, and this really drives those cyclical, unstable patterns of breathing. It can lead to turning off the muscles and closing off that airway. So this is how we do it in the lab. This is how we kind of figured out these different causes. We instrument people with all this gear and CPAP tubing, and they've got an epiglottic pressure sensor. We put fine wire electrodes into the muscles after a little bit of lignocaine anesthesia. They got a little hook on the end and a little wire exposed that allows us to measure the EMG activity. In this case, we're measuring tensor palatini and genioglossus EMG. Genioglossus, of course, being the main upper airway dilator at the base of the tongue there, as well as the standard sleep staging and arousal scoring equipment. They got that little epiglottic sensor that's sitting at the back of the throat there. And then, at least in a gold standard way, we have this device where anyone who comes in the lab, we can lower the airway pressure in the mask and actually start to, in a very controlled way, close off that airway and give them hypopneas and apneas. In this case, it was a healthy individual. We've got them on about 5 centimeters of water just to get that nice round airflow. And here we've dropped the pressure to about -2 centimeters of water, and you can see that the airflow's gone down a little bit. So I've just had a mild hypopnea here, and you can see here's that epiglottic pressure. So they're sucking harder and harder to breathe because the airway's partially narrowed. And here's the genioglossus EMG recording that I mentioned, that in this case is increasing over time as the CO2 and negative pressure builds up. These are the main drivers to the muscles to breathe, the muscles around the airway, that is. So the first thing we look at when we do this technique, we're lowering the pressure again and again throughout the night. We want to know, what's the relationship between the mask pressure and the peak flow in these first few breaths after we drop the pressure down. And ultimately, we want to know the pressure at which the airway is collapsing during sleep. So this is telling us about the functional anatomy. We then plot each of these breaths, so the peak flow versus the mask pressure. That's what each of these triangles here represents in this individual. Do different pressures until we can work out where that airway is closing off. And in this person, they've only got a mildly collapsible airway. It closes at about -4 centimeters of water. This person's closing at about atmospheric. And this last person's got really bad airway, and their airway is closing about +5 centimeters of water. And these people have all got sleep apnea and huge range in their anatomical vulnerability there. So that's the first trait we want to know. How bad is the anatomy, and ideally, how bad is the anatomy during sleep? Next thing we want to know is, are they able to recruit these muscles during sleep to activate these dilators and, potentially restore airflow when it's narrow, like that MRI example I showed you at the start, where that person had, really bad anatomy, but they didn't have sleep apnea because their muscles work so well. So is this a person with good muscles or not? And here's an example of someone with great muscles. We've lowered the pressure down. We've closed off the airway for 1 or 2 breaths. But look at what happens. Here's tensor palatini. Here's genioglossus. They got fantastic reflexes responding to that negative pressure and the buildup of CO2. And they've restored airflow without waking up because they've got great muscles. So this person's protected from sleep apnea and because they've got fantastic muscles. But the opposite is also true. Here's someone, we've lowered the pressure. The airway is getting narrower and narrower. They're building up more and more negative pressure, and yet there's no detectable increase in the activity of the muscles. And it's only in this case when they wake up having arousal from sleep that the muscles are reactivated and the airway reopens. So there's the opposite example of some of the bad bad muscles, I should say. And this is what it looks like. So we plot this with epiglottic pressure versus the EMG activation. Here's the second example of, basically a flat line. And here's someone with good muscles, that first example that I showed you. Thirdly, we look at the arousal threshold. So the pressure at which you wake up. So, this is about how hard you're working to breathe. You can use esophageal pressure. Here we're using epiglottic. And we just simply measure the pressure immediately prior to arousal. So the way this works is if, let's say you're waking up with a very low arousal threshold, and this is the case for some people, they're just very sensitive to small changes in airway pressure. They're waking up here, they've had no opportunity to build up enough stimuli to activate the muscles, assuming they can. Whereas as this person goes on, they're starting to build up more muscle activity. And if they had gone on a little further, then maybe they could have recovered from this minor airway narrowing event via those compensatory mechanisms. Second thing is, if you're waking up easily all the time, you're in light sleep, and your airway is much more vulnerable to collapse and sleep apnea in lighter stages of sleep versus deep stages of sleep. So that's a problem. And every time you wake up, you take a big breath. This is ventilator response to arousal, which then can blow off your CO2. And that leads into our last trait, which is what we call loop gain or respiratory control stability. And what we do here is basically we're looking at throughout these pressure drops, we can do them in this case up for several minutes. We can measure the reduction in breathing, and then pretending there wasn't an arousal here, we can then measure the ventilator response to this disturbance. And that's telling us about the sensitivity of the overall system to these changes in CO2. And we can quantify that. And so some people have a very big response and others have small. So this person, basically, they've doubled their ventilation, which is actually relatively small. Some people have, 10-fold increase in their breathing in response to a 1 liter per minute reduction in minute ventilation. That's a highly unstable system and can lead to, cyclical patterns of breathing and sleep apnea. All right, so there's the sort of detailed physiology. Here's what we see in a bunch of people where we measure these traits. So here's the anatomy, that critical closing pressure. So just the pressure at the airway is closing off during sleep when we lower the holding pressure down. Red dots are people with sleep apnea. Green dots are people who don't have sleep apnea, AHI on the x-axis. These people, none of them have sleep apnea. So it probably doesn't matter if their muscles don't work because their anatomy, you need more than -5 centimeters of water to suck their airway closed. So they got really good anatomy. The other non-anatomical traits don't matter. They're protected. These other people up here have all got, severe sleep apnea, 40 events per or more, because they got a really bad anatomical problem. Their airway is closing +5 centimeters or more when they're asleep. So really bad anatomy. But as I kind of alluded to, there's a lot of people out there who've just got a mild anatomical problem. And actually they overlap with people that don't have sleep apnea. So these people have got the same level of anatomical compromise. The airway is closing at between -2 and -5 centimeters of water. These people don't have sleep apnea. These people have mild. These people got moderate. These people got severe. And so, what is it then? It has to be those non-anatomical traits that's driving that variation. And indeed, that is the case. So, and theoretically, then you should be able to get these people over to there by just either fixing the muscles, fixing the arousal threshold problem, or fixing the loop gain issue. And indeed, when we studied these people, we found that all of these people in this range, anatomy range, they all had problems with one or more of their non-anatomical traits. Conversely, these people up here, if you just fix the muscles or the arousal threshold or loop gain, you might lower the AHI a little bit, but they're still going to have severe sleep apnea because you haven't dealt with the anatomy. They've got a really bad anatomical problem, and they're either going to need combination therapy or CPAP or something that really does deal with the anatomical issue to get below this golden -5 level. This is where we want to get people with therapy so that we can get their anatomy so that they need more than -5 centimeters of water to suck that airway closed, and that seems to protect people from sleep apnea. So that's really the goal of all therapies. So what we find, yes, as I mentioned, everyone with sleep apnea has some degree of anatomical vulnerability to airway collapse, but that ranges enormously from just a little bit right through to plus 5 centimeters and beyond in terms of their peak ret. A third of people wake up to it easily. A third of people are unable to activate their muscles during sleep without waking up. And a third of people have unstable control of breathing, too sensitive to CO2. And actually 70% of people or more people with sleep apnea have one or more of these non-anatomical issues going on that's driving their pathogenesis and contributing to their sleep apnea. So there's the sort of detailed physiology. What can we do to apply these concepts to target and deliver personalized therapy? So I'm going to give a few examples here: CPAP, oral appliance therapy, as well as emerging pharmacotherapies and combination therapy. And this is where this sort of palm scale concept came up with to kind of describe this and put it all together. So it's about the peak ret or the anatomy, arousal threshold, loop gain, and muscle response, palm scale. And here, this is what we would like to do in an ideal world to deliver physiology-informed care. As I mentioned, if we knew, first thing we want to know is how bad is the anatomy. And if we knew these people that only have a mild anatomical problem, and as I mentioned, they've all got one or more issues with their non-anatomical factors, we could then deliver the appropriate therapy or therapies to them accordingly. Conversely, these 20-25% of people got really bad airways. They probably need CPAP straight up or an aggressive anatomical intervention. Perhaps an oral appliance plus surgery might be required to fix their major anatomical issue. Most people actually fall in between, where they got a little bit of both going on. So the airway's closing at about atmospheric pressure. 2/3 of these people have one or more non-anatomical problems. And so either we got to get them below that -5 with the therapy, or in terms of their peak ret, or we need to think about combination therapies, depending on what's going on in their specific circumstances. So that's the kind of conceptual framework that we're trying to move towards with these approaches. So what we and others have been trying to do, again, this is purple of the non-anatomical traits. Here's our sort of anatomy up here, is we need to know the effect that each of these therapies can improve the anatomy as measured by our sort of gold standard peak ret technique. Because then we can start to make some estimates. Okay, if we knew this person, the airway's closing off at 0 peak ret, well, then what is an oral appliance or a mandibular advancement splint going to yield in terms of fixing that problem? Surgery, position therapy, weight loss, all of these improve the anatomy, but by how much? And I've listed the range here from the data. And I'll just give you one example. So the way that we figured this out, we did this detailed study. We used the John Remmer's device that he invented, the matrix, to kind of enable us to move the jaw from the control room while people are asleep. And they had all that physiology gear on, including EMG wires under the chin and so forth. And basically, we wanted to see what it did to the collapsibility of the airway. And what we found, perhaps not surprisingly, is the more we moved that jaw forward, so we moved it to 50% of their maximal range and then 100, the less collapsible the airway became. And here's all the individual responses and the group benefit here. So these were a pretty severe group overall. And look, some of them +10 peak ret at baseline, 6 centimeters of water. So, really bad anatomy to begin with. And you can see these kind of, and differences at an individual level. This individual's only had a mild improvement in their collapsibility. Others had, really quite substantial improvements. But overall, on average, you're getting about a 3 centimeter to a 3 centimeter improvement when you advance the mandible about 50% of their protrusive range. Or if you move it 100%, you're getting more like 5 or 6 centimeters of water benefit. Now, this was a small physiology study, but it did seem there was a bit of a hint that those that had a less collapsible airway to begin with, when we brought them back 2 or 3 months later and did a PSG, tended to be the ones that responded to oral appliance therapy. We also wanted to know, what does it do to the muscles? Because when you move the jaw forward, maybe the muscles work a little bit better. We didn't find any systematic improvement here, although there was a little bit of a hint. A more negative number here tells us that the muscles are getting more activation when the jaw's placed forward. We've actually gone on to do this now in more like 100 people non-invasively, and we did actually find that it does seem that when you give an oral appliance, that the muscles do work a little better than they did before. But the main way that an oral appliance work is, not surprisingly, it's improving that anatomical trait or the PCRET. Lots of studies now, more and more, and here's a snapshot that are telling us that if you know about the physiology, you can make better predictions as to who's going to respond to oral appliance therapy. So things like if your airway is only moderately or mildly collapsible, you're more likely to have a favorable response. So that makes sense. The people that are sort of in that 0, -2 range for their PCRET, that's roughly half of all the patients. We should be able to treat them with an oral appliance alone, because that will then, with the effect size that we know, get them to below that -5. Other things that also make sense is if you deal with the anatomy and it doesn't quite get the job done, and you've still got problems with your non-anatomical traits, for example, a high loop gain, then you're still going to be vulnerable to cyclical breathing and airway collapse if you haven't dealt with that factor as well. So things like a high loop gain are also a negative predictor of treatment response. And ultimately, here's a study that we did with Scott Sands and Andrew Wellman, where you can use models to put all the 4 traits together, and there's different combinations and pathways to treatment success with oral appliance therapy. But the take-home point is, the more you know about this physiology, the better results we can get, at least in all of these research studies, in terms of optimizing treatment outcome. Some other studies run by my colleagues in Sydney also show the more we learn about the anatomy and how this works. So this is looking at the pteromandibular raphe tendon. Some people have this, others don't. In this study seemed to be a predictor of treatment success. Now, again, we're not going to be able to go and do MRIs and measure it, but just the point being that, the more we understand about the physiology, the better it can help us potentially with predicting therapy. Again, we can't do these fancy MRIs, but what we noticed was that when we put it a mouth guard in during the MRI testing and pulled that jaw forward, the people that had this beneficial movement pattern were the ones that were most likely to respond to oral appliance therapy when we brought them back. And actually, there are efforts being made to do, using a simple ultrasound, you might be able to detect these motion patterns. So this could be something that you could use to inform, who might respond to therapy based on physiology. All right, what about other therapies? So we've got CPAP, of course, as the mainline therapy. So here's a study we did. We wanted to ask the question here. This was just in our hospital, public hospital in Sydney. We just took consecutive patients that came through with suspected sleep apnea. And we wanted to, look at the question, in non-obese people who have sleep apnea, theoretically, they're less likely to have more of an anatomical issue, and therefore we expected that they might have more problems with those non-anatomical traits that's driving their pathogenesis. And indeed, this was what we found. We found that, a very high percentage of those people who were non-obese for sleep apnea were estimated to have a low arousal threshold. So they were the kind of light sleepers. And so not surprisingly, when we looked at their CPAP uptake and compliance, they were impaired. So they were much less likely to take up CPAP or adhere to it when we brought them back and look at their objective data. And so that makes sense. These are people that are light sleepers physiologically. They did less well or less able to tolerate that physical intervention compared to those who did not have a low arousal threshold, which tended to be the more obese people. The Yale group has since gone on to do this in 2 other cohorts and find effectively the same thing. So, we think this is a very robust finding now, and that is that people with a low arousal threshold do not do well on CPAP, and either they need more help and strategies to help them transition to CPAP therapy, or indeed, this is not the right therapy for them. Okay, so there's just a couple of examples of how we can use this information to better target, things like CPAP and oral appliance therapy. How can we use it to kind of develop new therapies? So I'm just going to give a few examples here. So what can we do in the people that can't crank up their muscles enough during sleep? So these are the ones with the bad upper airway dilator muscles. We've got things like hypoglossal nerve stimulation, upper airway muscle training can be beneficial. So working with speech pathologists and experts to train these muscles. But I'm just going to focus on sort of pharmacological interventions here. So if we look at these muscles again, tensor palatini here, genioglossus here, when we go off to sleep, there's this kind of remarkable. The moment we fall off to sleep, so this is an alpha theta transition, there's a profound reduction in muscle tone to the upper airway dilator muscles, and in fact, our breathing goes straight down as a result. And so this is happening like that. And not surprisingly, this is a very vulnerable time for the airway, and many of us might recall that as we go off to sleep, that sort of sensation of maybe having some breathing difficulty, which is very vulnerable, particularly for people with sleep apnea. But if we knew neurochemically what was driving that loss of muscle tone as people go off to sleep, we should be able to give a drug or drugs to reactivate these muscles and stabilize breathing. So colleagues in Boston, these are Luigi Testata from Andrew Wellman's lab, and looked at data from out of Toronto from Rich Horner and his animal models that said that actually the noradrenergic system and the muscarinic system are particularly important for mediating these changes in muscle tone during REM and non-REM sleep. And so what the team in Boston did was take this drug, atomoxetine, a noradrenergic reuptake inhibitor, and this antimuscarinic, oxybutynin, combine them together and do some physiology. And what they found was the muscles were 3 times more active when you had these 2 drugs on board versus placebo. And it also had, quite profound marked reductions in sleep apnea severity in this single night physiology study. Sort of 65% reductions in the AHI, improvements in oxygenation. And in this study, the improvements in AHI occurred both in REM and non-REM sleep. So this is a study that we went on to do. This is Akia, who did her PhD in the lab here in Adelaide, and now she's with the Boston group there at Harvard doing her postdoc. And basically, we looked over a month, and we looked at different dosing regimes. And what we found was in this relatively small dose finding study was at the higher dose, there were this sort of sustained benefit in sleep apnea severity, and in particular, that hypoxic burden measurement was sustained here with reductions in hypoxic exposure over that 1 month period versus placebo. As a result of these findings, ApneaMed developed, Boston-based company, and have recently finished this phase 2 randomized trial. They're now doing phase 3 studies, and effectively showed, again, in the longer term and now in a larger group over that 1 month period, I believe, or could have been 3 months, but I think it's 1 month, again, with a higher dosing regime, about 50% reductions in sleep apnea severity with this drug combination. We also independently looked at other drugs with these kind of properties. We looked at reboxetine and another antimuscarinic, and looked at the muscles and found that we were actually able to activate tensor palatini here in these studies. And then that led to, actually, I haven't got it here. Oh, yeah, there's the AHI data in these sleep apnea people, consistent reductions in AHI and improvements in oxygenation. Another group in Italy have gone on and looked at reboxetine, in this case, over a month with oxybutynin in this case, and again, have seen marked reductions in AHI severity. They actually saw in this study improvements also in the next day alertness, or the psychomotor vigilance performance task here in the group randomized to the drug combination. When we looked at, we wanted to know, well, what is it? Is it the antimuscarinic or the noradrenergic agent? So Tom Altry, who's a sleep and respiratory doctor in our team, is just finishing his PhD. Basically, it showed us that actually the reboxetine or the noradrenergic agent was driving most of the benefit. The oxybutynin didn't add very much, but what it did do was helps people sleep a little better. And he also found here, getting back to the importance of these traits, was that if you know about the traits, well, actually it seemed to be the people with the higher loop gain, and these drugs, I should also say, actually lowered the loop gain a little bit. They were the ones that tended to have the greatest benefit in the AHI. All right, so here's a new target. We've got these great reflexes that I've kind of alluded to. So they respond to negative pressure throughout the airway, and you get this robust activation of the dilator muscles, genioglossus and tensor palatini, and these sort of reflex studies that we do. And what Amal did here, a very talented postdoc in the lab, is she went and gave this task channel antagonist. So this potassium channel antagonist, so the opposite of lidocaine, effectively. Rather than numbing the muscles, which we know can lead to worsening of snoring and sleep apnea, we tried to give an agent that would have the opposite effect and basically enhance these muscles and protective reflexes. And what she found, she delivered it in multiple different ways, and these I think it was about a dozen people with sleep apnea, was that there was a quantifiable improvement in the collapsibility of the airway, about the equivalent of 2 or 3 centimeters of water on average, which was about, the equivalent of position therapy, putting someone on from their side to their, back, well, the opposite, going from your back to your side. She's now then gone on, this has just published these data to show that there was some individual variability in terms of the benefit in airway collapsibility. But when we invited these people back, what we found was that the ones that had an improvement in their P-crit also had a reduction in the order about 25 to 45% in markers of sleep apnea severity, HI3, HI4, ODI, and other measures of oxygenation, whereas those that didn't have an improvement in their P-crit did not have an improvement in their sleep apnea severity. Interestingly, there was also a next day improvement in blood pressure in this acute study. And once again, the non-anatomical predictors are helping us here. So there did seem to be this relationship in that those that had a reduction in AHI, there was a relationship such that the ones with the lower loop gain tended to do better than those with high loop gain values. Small studies, but these are the proof of concept data. So what about hypnotics? What can we do there? Here's an earlier study that I did in Boston and basically showed that in people with a low arousal threshold, if you give them ezopiclone, you can increase the arousal threshold, and that actually lowers the AHI a little bit. And in this case, it didn't worsen oxygenation and improve things like sleep efficiency as well. Lots of data, lots of studies that we've tried since then, summarized nicely in this paper by Sophie Carter. We looked at a range of different hypnotics, what they do to the muscles in the airway. And so if you're interested in this topic, I would direct you to this comprehensive review article, but also to say that potentially you can improve the arousal threshold by non-pharmacological interventions, in this case, cognitive behavioral therapy. So this is work from Alex Sweetman in our team. He took people with sleep apnea and insomnia, gave them cognitive behavioral therapy, and that in of itself reduced the sleep apnea severity a bit. And we think that that's via, the shift in the arousal threshold, better depth of sleep, and therefore, better sleep promotion. Just to make the point, these are studies out of our lab from population study cohorts there in the US, showing that actually if you've got sleep apnea and insomnia, this orange line here, or in this case, the purple, very important outcome, survival probability, you are more likely to die earlier if you've got both of these conditions in an untreated sense, more so than sleep apnea alone or insomnia alone. So, challenging to deal with, but very common. 30 to 50% of people with sleep apnea have actually also got symptoms of insomnia that need to be recognized. What about this last trait where you can give drugs like acetazolamide can lower the loop gain, reduce the sleep apnea severity? Here's a nice review on this that kind of shows roughly 40% reductions in sleep apnea severity with drugs like acetazolamide. Here's another carbonic anhydrase inhibitor that shows also reductions in AHI with this, and improvements in the loop gain and the physiology traits that I've talked about. Oxygen also lowers your loop gain and can reduce your sleep apnea severity. So what about combining? I've showed you this is a heterogeneous disorder. Can you combine these therapies to optimize treatment outcomes and offer a solution? And indeed, here's some examples. So here in this study conducted in Boston several years ago now, just giving 2 agents that don't even touch the anatomy, so a hypnotic to increase the arousal threshold and oxygen to lower loop gain, you can roughly halve the AHI just giving those 2 non-anatomical interventions. Here's another recent study looking at those drugs to activate the muscles and lower loop gain a little bit, plus an agent to increase the arousal threshold, in this case, trazodone, that was leading to improvements in sleep apnea severity. So again, not directly dealing with the anatomy here, but dealing with all the other traits, you can have some benefit in sleep apnea severity. So we then took this knowledge and did this rather ambitious randomized, well, not a randomized trial, a clinical trial, I should say, where we recruited over 100 people, recommended for oral appliance therapy by their sleep physician. We brought them in the lab, we fully phenotyped them. Roughly half were responders, and they were then treated with an oral appliance when we brought them back 2 or 3 months later. But then we did add-on therapy based on their endotypes to try and treat that remaining 50% of patients that didn't respond first line to oral appliance therapy. Akia's work again, and what she really nicely showed us was, here's the benefits in AHI in this group that didn't, and our cutoff was we wanted to get people with an AHI below 10 on therapy. So you can see the oral appliance alone, as indicated by the mass here, improved the anatomy and the sleep apnea severity a bit, but all of these people by design still had some residual sleep apnea and a huge range in this population. We deliberately put, enrolled severe patients as well to kind of make the point here that actually we were able to treat half of these people that so-called failed oral appliance therapy just by giving them a positional device to keep them off their back. And then with these other add-on therapies, effectively we were able to almost treat everyone without CPAP therapy or CPAP as an absolute last resort. This person actually had a lower arousal threshold and couldn't tolerate the CPAP, but effectively the vast majority of people we were able to treat with these combinations of therapies based on their endotypes. So we kind of flip the care model, if you like. So here's a nice review that John Louis Pepin and I wrote with some help from Peter Eastwood, and it really summarizes how we can use these how we can apply the different therapies that we currently have and those emerging using this endotype model and how we can sort of tailor those therapy decisions. Obviously, very small writing here, but if you're interested, I'd encourage you to take a look and read this article. Okay, lastly, just to finish, what can we do to roll these out in the clinic? So we can look at things, many people, as I mentioned, end up on CPAP therapy after a diagnosis on sleep apnea. If we know their therapeutic CPAP pressure, that gives us a really good idea of what their peak cred or their anatomy is like. So higher pressures indicate that they've got a worse anatomy. If they haven't have a CPAP titration, you can look at the sleep study and look at the fraction of hypopneas to apneas. If you're having more apneas, you got more collapsible airway. And again, there's that relationship between that ratio and the peak cred, as shown here by Pedro Genta from Brazil. We've gone on to replicate this study in a different cohort, again, showing pretty good relationship between the therapeutic CPAP pressure and the peak cred. So, there's some things you can do that with information that we currently get clinically in the vast majority of patients. You can take the information from the sleep study. I mentioned the low arousal threshold is bad for, is a negative predictor for CPAP therapy. We can estimate that from 3 simple parameters from a sleep study: AHI, nadir saturation, and the fraction of hypopneas to apneas. You can put that together with pretty good sensitivity and specificity and work out who may not be a good, who may need a bit more attention in terms of their CPAP therapy potentially, or indeed advising other therapies, oral appliances, and so forth. We've built this palm scale predictor to actually now use machine learning concepts, and we've published a few papers on this now, where we just take the standard information from a sleep study, age, BMI, and 7 or 8 variables from a standard sleep study, as shown here. We can enter it into our interface, and we can get predictions on these 4 traits, or the palm scale. And actually, we've tailored algorithms based on just that clinical information, as shown here. And in this case, this is telling us that this person's likely to have a 50% reduction in their AHI and likely to get below 50, but they're not likely to get below 5 or 10 events per hour based on their physiology here. So this can help us predict, and indeed we now see prospectively, success rates 80% or more when we're using these simple principles. Well, it took us a long time to develop them, but they're simple to apply concepts. So we're trying to roll these out clinically now in our centers. We're doing lots of research to embed these tools so we can actually use them and make them available for everyone to use to better inform clinical decision making. We've got a TV series that's just come out here in Australia called Australia's Sleep Revolution, with a well-known British author and doctor and documentary maker in Michael Mosley. He actually volunteered for our study, where we really showcased a lot of the things I've talked about in this presentation, where we're rolling out these precision medicine approaches, not only for sleep apnea, but for insomnia as well, or the combination of the two. So I think this is going to go global after it's fully released here in Australia. All right, so just to summarize, immediate and clinical implementation takeaways. So this palm scale categorization, or OSA endophenotyping, can help improve outcomes with existing therapies. And I've given the examples of oral appliances and CPAP. The favorable characteristics of the people for non-CPAP therapies tend to be, and I haven't shown you all the other examples, but this holds true for surgery, for hypoglossal nerve stimulation, mild to moderately collapsible airway without major problems on those non-anatomical traits, or there are other combinations from knowing all four traits that can get you there to treatment success. People with low arousal threshold endotype do not tend to do well on CPAP therapy. And we can use these tools to develop and optimize the delivery of new therapies, including those pharmacotherapies and combination therapies, as I showed, that can help really target in on who should get these therapies and who's likely to respond and why. Lastly, simplified tools to translate OSA endophenotyping and precision medicine in the clinic at scale are actually in development. I showed you that approach with our machine learning one. The team in Boston have got some signal processing tools that they're working on. So lots of work on the way there, showing considerable promise. But there's some things we can do right now. So in the clinic, we can look at that apnea to hypopnea ratio, and as well as the therapeutic CPAP level, are associated with the peak grid. And I also showed that just 3 parameters from the sleep study can get an estimate of the arousal threshold and therefore indicate who may not be a good candidate for CPAP therapy. All right, I will leave it there, and a big thank you to the fantastic multidisciplinary team that we have here at the Adelaide Institute for Sleep Health at Flinders University. Thank you very much.
Danny, thank you. That's I've got pages of notes here, and I've seen this lecture before, or at least part of it before. So it's always easy to learn from a presentation by you. So thank you very much. I'm very curious about the clinical application, kind of starting at the end point of your talk, because as I was walking through the other learning with the medications and the arousal threshold, I thought, well, how do I put this to use? How do I convince the physicians who are prescribing patients to me or prescribing CPAPs? Then how do I convince them to pay attention to things that would give them a more precise way to prescribe therapy?
Yeah, look,
group showing.
Yeah, and look, I hope that presentations and forums like this, and the growing literature that's building, and obviously we're trying to raise awareness with that TV show that I mentioned. It's about raising that awareness and recognition that we can actually, in fact, our research has shown us we can treat most patients without CPAP. Now, often they need more than one therapy to get there, or actually not often, but in about half the cases, they're likely to need more than just one treatment. But this whole new way of doing things really does unlock that potential. Now, so I think other than continuing to do things like this and the science building in the background, and other kind of collective efforts that are underway. So I'm pleased to say the American Thoracic Society has supported an approach to deliver a consensus statement and a position paper on how we roll these tools out clinically to start, using these concepts. So that's something that we're working on this year, and hopefully will be out, next year or later next year, to really help guide the field and encourage people to take these concepts forward. But, there are some challenges remaining. We don't have all the tools ready to go yet to allow people to do this. So we need everyone to get on board to help us do that.
So this isn't an app or a website we can go to and plug numbers in yet?
Look, not yet. We are at that stage for our research. So we do have those tools available that we're rolling out in our research clinics. But ultimately, I would like to see these tools in your clinical report. And the same, you just do a diagnostic sleep study, and it gives you the predictions that I'm talking about to say, you know, what's their physiology and what are the likelihood of responding to various treatment options, so that the patient can have a conversation with their healthcare provider and select one or more of the most appropriate therapies for them to try based on their preferences and their physiology, which, you know, we're just not doing at the moment. It's trial and error.
Right. And same thing, oral appliances are trial and error too. So, hey, when you're ready to recruit some clinicians and some pure clinicians to put it to work, I'd love
Yeah.
to put an article like this in dental sleep practice, because you'll get people from all types of practice, not just the ones who are willing to read a research paper in, thoracic journal, which of course is, critically important. But
Yeah.
from a practical standpoint, I'm looking forward to being able to write stories about this and for DSP. Hey,
Yeah.
you mentioned many medications there, but medications are frequently associated with some side effects. And so I'm sure people have some concerns about potential side effects. What is your group showing for some of these norepinephrine reuptake inhibitors and other medications you're using?
Yeah, so absolutely. You know, any drug that we give typically has one or more side effects, and for those kind of drugs, so they can have weight promoting properties. So people, with that low arousal threshold or insomnia phenotype, that, there can be a weight promotion aspect to these drugs. That being said, that's where I think the antimuscarinic is being helpful, is because that's having the counter effect of actually causing sleep promotion. Now, that obviously, for the majority of studies that they've done, these people with sleep apnea who are already tired, that didn't seem to be a major issue. For people, their sleep efficiency was still good, and they were still having those improvements. And I showed you in that study by the Italian group, with the 1 week study, having improvements in next day function and psychomotor vigilance performance. The other thing it can do is increase heart rate. And so that's another thing that needs to be considered, and looking at the cardiovascular system and those other effects, dry mouth, these other things with the antimuscarinics are some of the typical side effects that we know with these drugs, because they're already drugs that are already out there that have been repurposed for this purpose. Now, the other spray that I talked about that's kind of novel, because that's not systemically absorbed, we haven't, again, we've just done small sample sizes at the moment in this proof of concept discovery work, but, we are not seeing side effects with those because it's not having that systemic effect. And that's the kind of nice thing, you're just touching the surface receptors to try and activate these reflex pathways. So, yep, need to be considered, and more work to be done on that front.
It does reflect the collaborative nature of treating these diseases, these problems, these physical traits, because a dentist is probably not going to be able to prescribe some of these medications given some of the cardiovascular side effects. But
Yeah, look, exactly. This is a multidisciplinary field, and absolutely work that relationship between the sleep doctor and the dentist is crucial to kind of, as all of these new options are opening up, having a good relationship between the two is absolutely crucial to work out all those risk benefit profiles.
can we log into the Flanders site and see that movie? Or see that TV series?
Yeah, look, it's a good question. I don't know if you can access it. It's a commercial. Well, it's a commercial station in Australia that's just about to release it. Actually, it gets aired next week, and we actually went to our Parliament House and studied politicians, and so we've got the Deputy Prime Minister in there doing these sleep studies, and it's we've done a lot of press on this in the last couple of weeks, but it's just about to launch, and it's on demand it's called SBS is the station. But I don't know if it's accessible. BBC also co-funded it from the UK. So I think it's going to go to air in the UK, and then they will probably distribute it via their network globally. But I don't know yet, Steve. We'll have to wait and see. Yeah.
I think what we'll do is I think we'll put a little research into that, and we'll put, if we can get to it, or the people that are watching this can get to it, we'll put a link somewhere. Maybe they can
Right.
add to it.
Yeah. I've got that link on that last page to our website, where we will be putting information up there for people to direct them to it. Yeah.
Here's an interesting question. You talked a lot about the breathing response and P-crit. Of course, that's obviously a kind of a central point. People that teach breathing coaching, how to breathe differently, how to breathe deeper and slower, and using less negative pressure, I think, to fill the lungs by their breathing pattern. Do you think that has any effect?
Look, I mean, there are those studies in particular around, didgeridoo playing with the circular breathing that led to, people feeling a bit better in terms of less sleepy in a randomized trial they did out of Switzerland many years ago now, published in the British Medical Journal. Gerardo Lorenzo Filho and colleagues in Brazil have shown that working with a speech pathologist and doing some actually training of the muscles. Now, whether breathing in itself changes that you do awake can then translate to sleep where it's automatic when you're asleep, I think would be, challenging to think that might transfer across. So I think it's probably more the functional effect it has on the muscles and other structures rather than breathing pattern per se, because, when we're asleep, CO2 is the main thing that's driving us. We don't have all that voluntary control over our breathing, and so yeah, that's my thoughts on that one.
Yeah, when that question came through, it was just about the time you showed that slide where the dramatic difference when people went to sleep, and on the graph
Yeah,
on the activity of the muscles, and I thought, well, that probably doesn't going to help during that time then. Yeah.
yeah, you got it. Yeah, yeah,
Um, now, you know what? It seems like a simple question, but it's still a little bit confusing about critical closing pressure, or P-crit, and its relationship to low arousal threshold, because honestly, it took me a long time to get this one sorted in my own head. A
yeah,
lower pressure is that a lower arousal threshold, and is the arousal threshold
yeah,
a brain thing, or
yeah,
is it a muscle thing? Or could you go over
yeah.
that again a little bit for us?
Yeah, yeah, look, absolutely. And these concepts I fully recognize take a while to think through. And the fact we've got negative numbers, low arousal threshold, is that good or bad, and what it all means. But you know, the basic concept is yes. So the more suction pressure you need to deliver to the airway, the better that air to close it off, the better that airway is. So in that sense, yes, lower, more negative P-crit numbers are better.
Right.
Now, with the arousal threshold, the more suction pressure you generate prior to awakening, uh, that's showing us that you're hard to wake up. So for your brain to respond to that, the CO2, the negative pressure that you're building up, it requires a lot of stimulus to wake you up. So that is absolutely a brain phenomenon from all those respiratory pathways that are going up to the sort of somatosensory area, the cortex, to register this and then finally trigger an arousal. So the low arousal threshold of the people are waking up too easily, whereas the high arousal threshold is actually means the ones that have got more negative pressure and they're actually more difficult to wake up.
Okay. Yeah, and those are the ones that are easy to wake up are the ones that have a lower CPAP pressure because, right?
Yeah, yeah, they are the ones that are easy to wake up. They are the ones that are more likely to not do well on CPAP therapy at all. And yes, there is also a bit of a relationship. People with a lower arousal threshold, on average, tend to have more mild to moderate sleep apnea as opposed to those who are more severe.
Yeah. So these patients that are given a CPAP, even no matter what diagnosis, like your first slide started off,
Mm-hmm.
are the ones that sometimes are mismatched to the therapy.
Exactly. Yeah,
Yeah.
this is, the more and more data is showing us these are people that are going to struggle with CPAP. Yeah.
So I think a big takeaway from this is going to be the research that you're doing and your other groups are doing are clearly showing there's a lot more data to be paid attention to than just the AHI. Now, we've known that for a while, but to really get precise about what can be done, and it includes oral appliances as monotherapy, but a whole lot more likely is going to be some kind of combination with
Yeah.
a medication, right?
Yeah, look, I'm excited about those data that we and others are showing now, that you can combine these therapies and provide solutions, and and that takes and that's where you could potentially use some of that monitoring technology in the home, rather than having to bring people back and figure out, did it work for you in terms of your AHI on that one night that as I've showed you, is noisy. You might be able to just use this tech in the home to modify things, and you counsel patient on the front end. You use our models to say, look, you've only got about a 50% chance of getting a response to oral appliance therapy alone. We're going to give it a try, but just be aware, there's a good chance we might have to add something on for you. Whereas this person say, oh, actually, it's more like 90% chance you're going to do well with oral appliance therapy alone, but we'll monitor it anyway, and we'll see how you go. So that's where I like, some of the novel tech that's coming out that can help the clinical care, not only in the diagnostic front, but the monitoring, which we haven't had. We don't monitor, sleep apnea in people with CPAP unless they're wearing it either. That's the only time you get a bit of an estimate from machines. They have to be wearing it. So, this kind of technology can be very helpful, I think.
Yeah, and it's becoming less and less expensive, a lot more ubiquitous
Yeah,
than it used to be as well.
yeah,
Yeah,
exactly, and much more accurate as the technology improves. Yeah.
great. Well, Danny, I want to thank you again for being with us. Folks, Dr. Eckert, if he's written over 200 papers, you don't have to read all 200 of them. I might have done that, but there's always look for a new paper by Dr. Danny Eckert and his group, because that is going to be the place that you will gather good information and some great questions for your collaborative team back in your area. And so as you learn more about this, as you are able to see clearer ways to treat your patients, as you're in collaboration with your physician colleagues, with your SLPs, speech and language pathologists, and other means, we'll get more and more precise about how we can help our patients breathe well every night through the work of Dr. Danny Eckert. Thank you to Panthera for supporting this. You guys make a great appliance to help us with this, part of our solutions. And it's wonderful that you support the distribution of science this way. So on behalf of MedMark Publishing, Dental Sleep Practice Magazine, and me, Steve Karstensen, I thank you for being here tonight, and I'll wish you all a good night's sleep.